Good afternoon, everyone. Thank you very much for Sages for the privilege of the podium. So we're going to get started. So I have no disclosures. So why are we talking about this today? Well, we know that a poorly constructed stoma definitely leads to difficulty with pouching, poor functional outcomes, and there are risks of complications with this procedure. And we obviously know as well that up to 50% of stomas that are formed in the emergency setting never get reversed. And this is particularly true for patients with an end colostomy during a Hartmann's procedure. Now, as I was doing my reading for this talk, I came across two quotes, which I think are pretty much the take-home message of what I'll be discussing today. That every stoma should be created to last a lifetime, since many temporary stomas are never reversed. And also, it's far easier to manage a difficult stoma in a good location than it is to care for a technically perfect stoma, but it's in a bad location. So what makes stomas challenging? Well, we know that there's preoperative variables such as body mass index, emergency surgery, previous abdominal scars, etc. But in the operating room, patients with who are obese or have a large panis and a foreshortened, thickened mesentery, we've all been in that situation where it's very difficult to get this up to the abdominal wall. The other question we have to ask ourselves is, we're creating this stoma, is it really necessary? Do we have to do this? And we have to understand the patient as well, their lifestyle, their living situation. Do they have any disability? For instance, if you're making a stoma in an elderly woman who's more or less independent, but now won't be able to care for their stoma, this is going to change her life completely. The other question we have to ask ourselves is, do we have to make an end stoma, or can we make a primary anastomosis and divert it further up? Consent is extremely important. When we discuss this with patients, once we reach the part of the discussion where we start talking about stomas, we can tell right away that the whole conversation just shifts and they start to worry. And what's most important is, when you're creating a stoma, is the site the correct site? So it's really all about location, where you put it on the abdominal wall. The Wound, Ostomy, and Continence Nurses Society has an excellent video actually online, and I'm just going to go through this quickly. But if you have to mark the patient yourself because there's no one available, you examine the patient in the sitting position. You want to avoid any creases or any folds. You also want to examine them in the standing or the bending position, and you want to identify your landmarks, such as the rectus abdominis. You want to make sure you're away from the ribs and that you're at least 2 inches away from any bony prominences, umbilicus, or creases of any sort. But if you're really stuck, you could always turn to the ostomy triangle. So your landmarks are the umbilicus, the pubic symphysis, and the anterior superior iliac spine. And then you make a little dot in the middle, seems to be the sweet spot. However, for more difficult situations, so marking a difficult patient, when you have a thick abdominal wall, you want to make sure you're marking superior to the umbilicus, above the line of sight, and I'll get to that in a second. Or patient with any disability, such as a spinal cord injury, for instance, you want to make sure you mark them in a position where they seem to be spending most of their time in. So this is just the line of sight. You can tell with the protuberant abdomen here. Anything if you're going to create a stoma anywhere below this line, they're not going to be able to visualize it. It's going to be very difficult for the patient to care for this. So keep that in mind. And we can just see by this picture how difficult this must be to pouch and take care of, and it must be miserable for the patient as well. The emergency setting, so we've all been there in the middle of the night. There's no one there to mark the patient. We have to do it ourselves. You have to think, if you're marking the patient for a permanent stoma, whatever operation you're doing, if you're removing colon and you're creating a colostomy, if the colostomy is not going to be a nice one, maybe you're better to just complete the colectomy and do an endoleostomy. It'll be easier for the patient to handle. If it's a temporary stoma, loop stomas are much easier to take down later on. The other thing is that if you have that really thick colon that you bring up as an end colostomy and you're just not able to avert the edges or to sew it to the skin, suture it to the skin, what you can do is just suture the serosa to the skin and just leave it there, and it'll mature on its own. And I've seen this, and it actually gives her a really nice stoma. It doesn't look nice initially, but after a month or two, it actually works out pretty well. And I had this situation. This is not my patient, but I didn't take pictures. I kind of regretted that. But I was in this situation about a week and a half ago. A patient who we had to leave the belly open, and I had created an ileostomy, and we were trying to figure out how to get a good seal on the abdomen. This is a wound crown that you can put, and then you go ahead and place your vac. You protect it with the little Raytec, and then once you get that really perfect seal, you cut it out, and you seal it with some good old stoma paste, and it seems to work very nicely. So So once you've figured out the location, now you have to actually create your stoma. How do you think about it? Think about it as an anastomosis. As Dr. Cataldo said in his paper, each stoma is an enterocutaneous anastomosis, and the principles are important to any anastomosis extend to stoma. For instance, length. So if you're creating a colostomy, you want to make sure you're mobilizing along the planes. You want to perhaps ligate the inferior mesenteric artery or vein, or if you're creating an ileostomy, you want to make sure you really mobilize the small bowel mesentery all the way up to the duodenum and maybe ligate the ileocolic artery if needed. In patients who are obese, so the goal is to make the end of the colon smaller and to make the opening bigger, maybe accepting the risk of peristomal hernia in this case, but what you can do is remove all of those epiploic appendages, trim the mesentery without disrupting the marginal arteries, so without devascularizing the colon, decompress the colon if it's very distended, and to make the opening bigger, what you want to do is just kind of remove all that subcutaneous fat to make a nice opening in order to pull it through. Another nice trick that I've used before is using the Alexis wound protector. So you can appreciate how thick this abdominal wall is. And you have to bring this through here. But what this does is as you invert it and you place your retractor, it kind of compresses the abdominal wall, so it makes for a shorter distance. But you have to cut it though here in order to pull it out. Other ways it's described is using a glove if you don't have access to the wound protector. And other tips are mesenteric pie crusting. So you're scoring along the overlying vascular pedicle. You know, we do these maneuvers when we're preparing for our ileal J pouches. You'll get a good 2 to 3 centimeters more to bring it up. You don't want to pull it through. You don't want to tear anything, but it's better if you just kind of push it through. And sometimes you have to, weigh the pros and the cons. You might want to mature the stoma prior to closing the abdomen. I know we don't like doing this because of the risk of contamination, but if you have any type of, if you're worried about ischemia or vascular supply, it allows you to kind of give a little look and see if the bowel that you're bringing up to the abdominal wall is still viable. The loop end stoma, this is also very practical. You can bring up here your end ileostomy because it just doesn't come up straight or it doesn't look nice. You just go a bit more proximal and bring it up and you mature it like a loop stoma. Patients who've had reoperative surgery, many scars, this can be very hard. That hostile abdomen where you're marked preoperatively, but the stoma just doesn't go to that site, you might have to just unfortunately bring it through the midline. You just got to accept it and just move on and deal with it after. You tried. That's the best thing. So in patients who are critically ill, we touched upon this earlier on, so I'm not going to speak about it in more detail. The Turnbull stoma, just a little trick, I guess, is that if you want to, because this can also be done at the bedside in the ICU, if patients are too unstable to go to the OR, and you put a radiopaque marker on the xiphoid process, you locate your transverse colon, and then you could kind of measure under local anesthesia, dissect down, and go ahead and it's not the nicest stoma, but it does the job. I'm going to mention stoma rods. I'm guilty. I do use them every once in a while, but there is evidence out there that in non-obese patients, it's pretty clear that they're not necessary. I'm very selective of who I put these rods in. I've had obstructions. I've had kind of the mucosa change color a bit when I put them in, so they're not benign. You can have complications from this. So what can go wrong now? Just quickly touching on complications. Up to 80% of complications can happen with stomas. Roughly half of stomas that you create will become problematic from a pouching standpoint or any type of peristomal skin issues. Loop or end ileostomies we know can lead to dehydration, skin irritation, bowel obstruction. Loop colostomies tend to prolapse. And all stomas, you have issues of peristomal hernias and retraction. So with regards to patient-related factors, similar to any operative risk factors, but things that we can control, such as surgical technique and the input from a preoperative ostomy and continence care nurse is very important. And when you look at complications, either very early, so within days postoperatively, within 3 months, and we're going to touch on these very quickly. So bowel obstruction, we've seen this. This is very early on postoperatively. You notice that the patient is just not opening up and you have an obstruction right at the fascial layer. You could attempt to put a Foley catheter in to try to decompress it, but if it's really tight at this point, it's probably best to just go back and open it up a bit more. Stoma necrosis, so in the obese patient, it's 7 times more likely to have this. What's really important in this case is that you have to identify whether the necrosis is either above the fascia or below the fascia. If it's above the fascia, fine. You could leave it like that, just with little gentle debridement. But if it's really below the fascia, the patient needs surgical revision, and this is the famous test tube test. You shine a light, and if it's nice and pink inside, you can take a breath. everything should be okay. Stoma retraction, this can happen, usually a tension problem. So there's a problem with tension when you brought up the stoma, and management really depends upon the degree of retraction and if there's stenosis associated with it. With mucocutaneous separation, this can happen from tension as well, but can also be secondary to maybe excessive cautery use on the skin, on the bowel mucosa. If it's detected early on, then aggressive wound care is great, but sometimes you do need to revise it operatively in order to prevent retraction or stenosis from happening. Stoma stenosis, this is mostly with colostomies, again, due to poor surgical technique or just disease, such as inflammatory bowel disease or malignancy. And if it happens immediately post-operatively, if there's some edema, you could manage that with a large rubber catheter and decompress it. But if it's at the level of the skin, some patients actually are, don't have any complaints from this aside from the way it looks. But if they're really struggling, local revision is likely necessary. With regards to prolapse, loop colostomies tend to be this tends to happen more often, and it's the efferent limb that prolapses out, and for a variety of reasons. And there's no strong evidence that mesenteric or fascial fixation at the time of creation prevents this from happening. Usually it's managed conservatively, and what you can do also, if it's really bothering the patient, is kind of well, as I wrote Altmaier, but it's the same concept. You would just go across the intestinal wall circumferentially, and then you would mature your stoma from there. And what's also described in the literature is the stapler technique, where you would do 2 vertical lines, staple lines using your stapler, leaving a cuff of about 1 centimeter from your mucocutaneous junction. So you do end up with a staple line over here, but that's also described to deal with this. Scoring the seromuscular surface to promote fixation in this kind of bidirectional seromyotomies has also been described. And then, lastly, I'm going to mention parastomal hernias, but there's a few talks about this during our conference, so I'm going to leave it at that. But we all know that in asymptomatic patients, when you image them, roughly 80% of them will have some form of parastomal hernia. And with regards to prevention, well, there is, we did speak about, in the past, we were talking about prophylactic mesh placement a few years ago, and there were studies showing that this might help. But now with more recent studies and randomized control trials that we're kind of swinging the pendulum towards, they're finding there's no benefit to putting a mesh at that time during creation of the colostomy. And then according to the ASCRS guidelines, the most updated ones from recently from 2022, that they don't advise putting a prophylactic mesh in order to prevent a parastomal hernia. Lastly, extraperitoneal tunneling. This, however, has been shown that it could help. However, it's very technically challenging. You need to have experience with this. You need to have special instruments in order to tunnel the colostomy in this fashion. So it's quite challenging, but there is some evidence out there that it does decrease the risk of parastomal hernia. So in conclusion, stomas are not benign. It's definitely life-altering for our patients. You need to prepare and plan, and education is really key. And it's a multidisciplinary approach. So involved our nurses, our specialized nurses in these patients' care. So I just want to bring back my take-home message from the beginning that, it's a lot easier to manage a technically challenging stoma in a good location than it is to manage the most beautiful stoma, but it's not located in the right place. Thank you.